Our presentation topic for today is titled Partnering with Your Healthcare Team. Can you go to the next slide, Jamie? We'd like to take this opportunity to thank our host site partners from the Aging and Disability Resource Centers in Brown, Crawford, Dane, Dodge, Grant, Greene, and La Crosse counties and Oneida Nation. Crawford is one of our brand new partners that is joining us today and will be part of our satellite location sites for 2026. So welcome to Crawford County attendees who are joining from that site. These partners are instrumental in helping us expand the reach of this program across Wisconsin and beyond. So thank you to all of our partners and thank you to all who are at those satellite locations joining us today. We're glad that you can make it. Before we dive into the first part of today's programs, Ben, can you take a few minutes and share some housekeeping items with everyone?
Sure, Jen. And thanks again to everyone for joining us. A few things. Our program is being recorded today, and it will be saved and housed on the Healthy Living with MCI webpage. We will edit the recording prior to posting it to remove everyone's identifiable information, block out faces. So, nobody that's here, no one will know that you were part of this. So it'll just be posted a few weeks. It takes a little bit of time for that to get posted. We have a large audience today, so we ask that during the presentation, you please keep your microphone muted. Obviously, once we have open up for questions and things, we can unmute and things like that. But during the presentation and once we get going, we'll try to keep everyone muted if it's someone accidentally unmutes themselves. So don't worry about that too much. We have time for Q&A with the guest speakers and Dr. Chin built into the program, so feel free to add your questions to the chat. That's probably going to be the best way to get your clearest question on is put it in the chat, and we can either summarize or we'll try to get to them as many as we can during the time that we have. Today's program runs until 11:30, and we do have a scheduled stretch break at the midpoint of the presentation. We'll have some nice, informative, and pretty current videos. I think there's one that's a brand new video about MCI that's going to be in that little break time. So if you want to just hang on and watch that, otherwise you can feel free to get up, move around, get a snack, use the restroom. In my case, I definitely have to do that. Yeah, that'll be. If there's any questions or issues or anyone's having trouble with anything, you can always put a note in the chat as well. I'll be keeping an eye on it as well as Jamie, and hope everything goes smoothly. Thanks, Jen.
Thanks, Ben. So let's get rolling. Dr. Chin, it's always great to have you join us for these presentations. And for those of you who are new to taking part in this series, Dr. Chin is very active in the Q&A portions of the programs, and he is oftentimes just going into the chat and directly answering questions. But today, every now and then, he is our featured speaker, and today is one of those days. So it's a treat to have you presenting today, Nate, and I'm going to do a formal introduction of you, if that's okay.
Oh, you can, but be brief so we can talk more about Kari.
Awesome. So Dr. Chin is the medical director and clinical core co-leader with the Wisconsin Alzheimer's Disease Research Center, and he's also the medical director for the Wisconsin Registry for Alzheimer's Prevention, and this is also known as the RAP study, for those of you who might have heard of that before. While completing his internal medicine residency at the University of California, San Diego, Dr. Chin's father was diagnosed with early onset Alzheimer's disease. His father's condition influenced the way that he began to look at his own career, and he decided to pursue a career as a geriatrician and scientist focused on dementia, specifically Alzheimer's disease. Dr. Chin sees patients at the UW Health Memory Clinic, and he is also the host of the Wisconsin ADRC podcast, Dementia Matters. This is a bi-weekly, it has bi-weekly episodes, and he interviews local and national Alzheimer's disease experts about research advances and caregiver strategies. We also have two additional guest speakers with us today, Sarah Gunderson and Kari Esser. And Sarah is an occupational therapist, and Kari is a speech language pathologist. As part of their work at UW Heath, they support individuals affected by a range of neurological conditions, including stroke, brain injury, multiple sclerosis, and Parkinson's disease and dementia. So, Kari and Sarah, we're so happy you guys can join us today as well. And Kari and Sarah will be doing the second part of today's presentation. So thanks for joining us, ladies.
Thanks so much for the invitation.
Yes, thank you.
So Nate, I'm going to turn it over to you and you can get us started.
Wonderful. And I do think Kari and Sarah are our featured speakers. I'm here to provide some background that I think will enhance the things that they are going to talk to us about. And it would be my dream in a memory clinic to have Kari and Sarah built in to the clinic so that we could provide this true interdisciplinary approach. And until that day happens, this is what we're going to have. And I think this will be very helpful. So let me share my screen. And my mission is to really give you some basics and background on mild cognitive impairment, and then a newer term that we're using, subjective cognitive decline, and how that's going to be impacting the field primarily right now in research, but certainly it will eventually make its way into clinic. And so to begin, these are the questions oops. Did I lose it, or is it still available? Are we people seeing my screen? Okay, good. So
I
these are
can
the questions.
see your screen, but it isn't in presenter mode. I don't know
It's
if
not
that
in
makes
presenter mode.
yeah.
Okay. Let's see.
There is something weird. Yeah.
Okay. Does it look okay now? Okay.
Yep, looks good.
So these are the questions that I'm going to be addressing in my talk, and of course, we'll have access to these slides afterwards. All right, so one of the key questions that come up are what's the difference between just getting older and normal age-related change and something that might not be normal aging? And so what I'm showing you here on the horizontal line is just age. So we're getting older as we go left to right. And then on the vertical line is what we call cognitive function or thinking abilities. On the vertical line here, and that is really we're losing ability as we go top down. And there aren't a lot of studies that look at the lifespan of an individual from early life to late life. But what we do know from the few studies that we have are that when we think about cognitive ability, we're really thinking about the multiple different domains that neuropsychologists test for, and that's learning and memory, our ability to focus, the language, both receiving information and providing information, and then what we call executive function, which is a really important, often not understood concept of what we do when we're problem solving, multitasking, reasoning, and then our visual spatial ability, how we perceive the things that we're seeing, our own body's place in space. And so when I say cognition, and certainly when Kari and Sarah talk about cognition, they're going to be thinking about all of these different abilities, not just memory. But when we think about these changes as we get older, the key takeaway here is it's not a straight line. There is this slow decline. And actually, it starts usually in the mid to late 20s. So we are at our peak in our mid 20s. And then we have very subtle changes that we don't really notice until about our mid 60s. And it's unclear why it is in our mid 60s that many people will tend to notice these changes. It's possible that it's just this accumulation of subtle change over time, or perhaps there is a slightly faster change here, the actual rate of change. But either way, this happens to be coincide in a time when people start to think about the later part of their life and the risk of developing a brain condition or dementia. But the changes that can happen that are normal are listed here. And so episodic memory is the things that have just happened to us, details of conversations and events, our processing speed, our learning ability, the tip of the tongue phenomenon of coming up with someone's name or a fact or a piece of information in the midst of conversation. And that tends to be one of the scariest but more common complaints that we get from individuals, along with the I'm walking into a room and I forget why. These are all considered to be normal. Unfortunately, they could also reflect the beginning of a real change that is not normal. And so, in truth, we really do need a clinical evaluation to differentiate the normal from abnormal. And that's where a trained healthcare provider can really hear the things that a person is noticing, order some tests, do cognitive thinking tests to try to figure out normal from abnormal, and then also figure out what is causing it. This is just a recap for those of you who aren't as visually oriented and prefer to have words here. This is just an overview of the things that I've mentioned. But I do want to pay attention to the bottom two bullets here, which are that normal age-related changes are typically subtle. They're not interfering with our day-to-day abilities. They're not happening all the time, so they're not persistent, they're not consistent, and they shouldn't be distressing to a person. And in addition to that, there are things that improve over time: vocabulary, wisdom, emotional resilience. So not everything about normal aging is about change in a negative direction. There are positives as well, as many people here can attest to. Physiologically, what is happening in the body when someone is getting older? Well, when it comes to the brain, we do see natural age-related shrinkage, which in the medical field is referred to as atrophy. So a brain which in their 20s is nice and big and plump, that gets smaller over time, but still is normal and it still is functioning normally. And that shrinkage is due to the loss of brain cells, but also the loss of the connections among brain cells, which we call synapses. And one of the reasons for that is that, like the rest of our body, our blood vessels aren't perfectly open. There is some narrowing that develops, and you can see here in the far right side, there's no blockage here. And as one gets older, we tend to see maybe this one looks a little bit more significant, but we can see more age-related narrowing. So if this is normal aging, then abnormal aging, the broadest term would be cognitive impairment. Again, that doesn't really specify what's happening or how a person's feeling, but it's sort of a broad medical term. And the two main criteria for cognitive impairment are a change in a person's memory or thinking, that cognition. And it's subjective. It is either the person experiencing it, a family that's noticing it, or a clinician that's observing it. And then a form of objective testing to really confirm that a person has a lower than anticipated score for their age. And so this is really an umbrella term, cognitive impairment. And there are two more umbrella terms underneath this, which many people are familiar with: mild cognitive impairment and then dementia. And those are the two diagnostic terms that we use in the clinic. But there are two emerging terms that we're using in research. One is called subjective cognitive decline, and another one, which I won't be talking about today, is mild behavioral impairment, where it's not thinking ability that's affecting a person, but actual emotional mental health that's affected first. So what exactly is subjective cognitive decline? And I don't usually present on this, so this is newer for me to share with everyone. And it's very word heavy, so I apologize in advance. But I thought it was important to get all the information out there. And in subjective cognitive decline, or SCD, it was a condition that was really developed theoretically in 2014 by a group of expert researchers and clinicians who were investigating Alzheimer's. And at the time, they were thinking about Alzheimer's disease, the biological process, but it has since expanded to all forms of thinking change. But they defined two major features here. And they said a person who is experiencing persistent decline in their cognitive ability, and that's compared to what they would define as their normal ability, and not normals, this is what I was like 20 years ago, but normals, and this is what I was like a few years ago. And it was not related to a particular event, like a stroke or a hospitalization. And then they would have that objective testing that was considered to be normal or within normal. And it's the same testing that we would use to identify mild cognitive impairment. They found that there were many potential causes, and many of them were reversible, but sometimes it really was the earliest form of subjective change related to Alzheimer's or Lewy body or Parkinson's disease. And so the evaluation that they're really encouraging in the research, but eventual clinical field, is to look at what part of those cognitive abilities is affected. Is this really worrying and distressing the person who's experiencing the change? And then to investigate, when did this actually start? Understanding the context, and is there any sort of relationship to mental health or physical health or relationship to substances? And so when trying to differentiate subjective cognitive decline from mild cognitive impairment, that thorough testing is really important. So they are really indicating these brief screeners that you might have in a primary care clinic are not helpful in this regard. And I would emphasize that point. If we really want to detect early change, it's going to take a more thorough evaluation. They do feel like, based on population studies, so just looking at large groups of people, that 50 to 80% of adults who are 70 and older might actually be experiencing subjective cognitive decline. It is not an uncommon condition. And many of them are going to have reversible causes, but based on at least those who were followed for 4 years in research studies, 27% of them declined to mild cognitive impairment and 14% declined to dementia, indicating that if we can capture these individuals early in clinic, perhaps we can provide those interventions and either delay or prevent this progression. They found certain risk factors may be helpful in identifying and then allowing us to provide more treatment. And that would be if a person had a memory-specific decline, if there was a more recent change within the past 5 years, suggesting that if you've noticed gradual change over 10 years and you still don't have mild cognitive impairment, it's unlikely that it will truly progress. Those that are older, those that are worrying about this decline more than others, and if the person close by, a family or friend, is also worried that that might be more suggestive. As many of you know, in Wisconsin, the Wisconsin Center of Research, we are very focused on biomarkers, the tests that we can get to look at pathology of brain disease. And there has been active research in this field for this group of individuals. And they're finding that of those seeking medical care with subjective cognitive decline, there's a wide range that will have abnormal biomarkers indicating the presence of Alzheimer's disease. And of those with those abnormal biomarkers, many more of them will progress clinically than those without them. And so this is a really important area in the research field. But I also think it's very validating to those who are experiencing symptoms that might otherwise feel dismissed by others, including healthcare providers. So then moving on to mild cognitive impairment, this is not a normal part of aging, but it's also not the same thing as dementia. And so mild cognitive impairment, very much like I initially defined cognitive impairment, a person's going to have a thinking change. It is going to reflect a decline from what they perceive to be their baseline. They're going to have a lower score on, I would argue, a more rigorous objective thinking test. But day to day, they're still functionally independently. They're not needing someone else to do something they have historically done. Mild cognitive impairment is a very broad category, and it allows for many different conditions to cause it. So you do see here your top 5 brain conditions: Alzheimer's, vascular disease, Lewy body, frontotemporal, and Parkinson's disease. But it also allows for many conditions that are treatable, reversible, that happen below the neck. And that would be medication side effects, mental health, sleep issues, sleep apnea, vitamin deficiencies, endocrine abnormalities. And so it's really important for healthcare providers to be exploring and investigating these so that we can identify and treat them. For those that do have mild cognitive impairment, they are not alone in this condition. The prevalence of this increases with age, and you can see this, that as one gets into their early 80s, 1 out of 4 people will experience this condition. I anticipate these numbers will likely go up as more people are aware of it and are getting diagnosed. The progression from normal to mild cognitive impairment is about 5 to 6% per year, or 5 to 6% overall of 70 and older. We tend to say about 10 to 15% per year will progress from mild cognitive impairment to dementia, but that's always in an individual situation. But I would also argue here that means at least 50% or around 50% of people are not going to progress after 4 to 5 years. If you do have a brain disease that's causing your mild cognitive impairment, meaning Alzheimer's disease or Parkinson's or Lewy body disease, it is more likely that you're going to progress in that shorter period of time because we don't have a way of stopping the progression of that brain disease, at least right now. But there are plenty of people that do convert from mild cognitive impairment back to what we would call an unimpaired state, where they're testing back in the normal range. They may still experience symptoms, but they overall are feeling better. So I think of mild cognitive impairment as a sort of a prognostic conundrum. It's harder for me to predict what a person's going to be experiencing because some individuals will truly just stay in this mild cognitive impairment phase forever. Others are going to progress to dementia. Some will get better and go into this unimpaired state. But even those that improve into the unimpaired state, years later, they might progress to the next stages. So it's really hard to know what someone's future looks like. But it does, for me, that illustrates the importance of really understanding what's happening, defining it, and then helping people whichever direction they end up going. Now, one of my colleagues, the neuropsychologist, Dr. Tori Williams, has shared this with me because it's important for us to know the risk factors for mild cognitive impairment other than just age. Those that are male, that have had a lower educational attainment, if you have the genetic risk factor for Alzheimer's disease, called ApoE, vascular risk factors like diabetes, high blood pressure, weight, cholesterol issues, smoking, these are all modifiable. Other cardiovascular disease, things like heart disease and atrial fibrillation, and then certainly depression, anxiety, and inflammation are all risk factors for developing MCI. So MCI, again, it's not normal aging, but it's really MCI and dementia, they're not diseases, they're the consequence of disease. And when we think about the 6 main brain diseases, you can see them here: Alzheimer's disease, vascular disease, Parkinson's and Lewy body I consider to be on the same spectrum, and then frontal temporal disease and a condition called late limbic predominant age-related TDP-43 encephalopathy. That is a mouthful. That's why we call it late. And these are all due to proteins building up in the brain, excluding vascular, which is blood vessels getting narrower. But you can see here that it is biology that's affecting our brain, and then that's what's actually killing our brain cells, and that's the cause of the symptoms that people experience. I'm showing you on the right here the breakdown of sort of how common these are, and you can see that Alzheimer's disease remains the most common. However, vascular, Lewy body, frontal temporal are also becoming at least more identified, and they're recognized as they're happening a lot too. This concept of mixed disease is actually really important and really at the forefront of the research that we're conducting and that our field is conducting, because we're learning that more and more people have multiple processes happening in the brain leading to their mild cognitive impairment and dementia. And so these are 2 studies that have happened within the past few years. The one on the left is from 2024. The one on the right is from 2022. And our center is a part of a network of centers that share data to this conglomerate, and that way other researchers from around the world can investigate and do their own studies. But one of the most important pieces of that research is that our participants, some of them will donate their brains to science. And that really is the last most important piece of research because it is the ultimate gold standard way of identifying what has happened to the individual. And in both of these studies, over 2,000 brains were studied, different brains in the studies. And what they found was that only about 1/3 of the time was Alzheimer's disease present on its own. But 2/3 of the time, Alzheimer's was present with either Lewy body disease or frontal temporal disease or more significant vascular disease. And in this study on the right, the one from 2022, they showed that those that had multiple brain diseases also had faster courses of decline than people who just had one disease. And I think that's a really important thing because, again, everyone's course is different. and we're trying to understand why that is. Certainly, brain resilience and other health factors are there to that impact this, but so does the presence of multiple brain conditions. When we think about Alzheimer's disease itself, it is this process of developing amyloid protein first in the brain. It's at least the first identifiable protein that's very specific to Alzheimer's. And we can now do this in PET scans and spinal fluid and blood. And then years later, the second protein develops in the brain. We can detect it in the same way, and it's called tau. And tau actually forms inside of the brain cell, whereas amyloid's outside of it. And tau is what's closely related to a person having symptoms and declines on testing. And that's because tau is very much related to brain cell death and atrophy. But all three of these things can occur without a person noticing. So they're above this hypothetical green line because you really can have no symptoms, or what we call asymptomatic, and still have Alzheimer's disease. Eventually, there's enough change in the brain that you will develop symptoms. Hopefully, you get evaluated early. You're diagnosed with MCI. We can ideally have more interventions to help a person here. But because we can't stop the progression of these proteins, at least on their own, without the newer medications, people are progressing to dementia. I have a picture here of medications because that tends to be one of the first changes day to day that a person experiences, leading to that sort of qualification for dementia. So I wanted to show you that original figure again, the normal aging curve. But now I've added this gray amorphous structure, and that represents accumulating brain changes. And what I mean by that is the buildup of amyloid and tau, or perhaps it's the narrowing of blood vessels, or perhaps it's the buildup of other proteins causing Lewy body disease. But either way, this happens years to decades before a person actually has symptoms. And so they're starting to eventually change here in this overlap, but this red line indicates a deviation from normal aging. And then eventually they'll have symptoms and be diagnosed with mild cognitive impairment and then be diagnosed with dementia. So this is my attempt to overlay biology with the things that matter most to us, the people, the symptoms that they're experiencing. And because of this, it's really important for us to go as early as we can in identifying change, both biologically and symptomatically, so that we can provide earlier interventions and ideally either prevent this red line from ever happening or at least slow it so that it's not the same sort of degree of change. And with that, I wanted you to know the things that I talk to my colleagues about, and in particular the primary care world, because really the primary care provider is the first line in identifying and helping a person who's experiencing a thinking change. So this is a slide that you all are seeing now that I routinely share with primary care providers, where I emphasize nothing can usually be done in one visit. And it's a multiple step process. And so we have to be patient, which I know is hard to do, but it is required because there's so many different components to a memory or cognitive evaluation. And the most important parts are these first two boxes. So despite the things that we're excited about in research with biomarkers, the most important things remain a conversation between or among a patient, their family, and their healthcare provider. And that's because we really need to understand what kind of cognitive and functional changes the person's experiencing. We need to be looking for reversible factors. That's their health conditions, their medications, their mood, their sleep, their hearing, their vision. And then we start exploring biologically or with tests what's actually there. So that's where we get blood tests. We can get head imaging. We do a physical exam looking for Parkinson's disease. And then we want to see how is the brain actually performing. And usually in primary care, it's that briefer exam that's about 10 to 15 minutes. If you come to see one of my colleagues or myself in a memory clinic, it's usually about 45 minutes to an hour. That cognitive history is so critical that it is the foundation in which we have to start our investigation. And it starts with someone identifying a symptom. So ideally that would be a patient with those changes or the family, but sometimes it's the provider or it's done through routine screening. Your annual wellness visit is a wonderful opportunity for a healthcare provider to ask about this. I'm encouraging more conversations with people really over the age of 40, but certainly during a Medicare wellness exam to just ask the question of, do you feel like your memory or thinking is worse than 5 years ago or 10 years ago? We also have free validated questionnaires that can be used. The 88 is promoted by the Alzheimer's Association. There's easier ways for us to capture, at least start the conversation and destigmatize this idea of thinking change. Once we know that there's a symptom, we want to know all of these details, which can feel very lengthy to a patient and their family, but it's really important for us to know how long a person's had the symptoms, what was going on at the time, what has it been like over time. For instance, someone who hasn't noticed much decline, perhaps it's less likely then that it's a brain disease and more likely something else like poor sleep. Whereas if it's gradually worsening over time, that might be suggestive of vascular disease or Alzheimer's disease. We want to know specific symptoms, not just I'm forgetful, but how forgetful, when does this happen, given examples. And then we do need to be very holistic about this. How has a person's mood and personality and behavior responded to this? How are these reversible factors affected? And then understanding their medications, their medical history, their family history, and certainly substances, which are more and more important as we get older. Function is a really, oh, I'm sorry, early symptoms are a really important piece of this. And I'm not going to go into this in great detail, but for those of you watching, it isn't always going to be memory loss. And sometimes it's going to be problems understanding words or problems with word finding, visual spatial, difficulty recognizing people or getting lost, or just really misjudging your hand movement as you're reaching for something. And then I mentioned executive function is so important in our day-to-day abilities that we don't recognize what our brain has to do in order to reason and organize and multitask. If we want to get to the earliest change, it's going to be thinking symptoms and not driving or cooking or cleaning. Those are important, but they're not the first change. And when I think about that functional history, I think what's so important is that we want to know what the person's experiencing, both from their perspective as well as from someone who knows them well. And we can do this in many different ways. Those of you that have come through my clinic know that we use a checklist and sometimes we use these validated questionnaires. But really, these are just meant to be conversation starters so that we can understand on a specific list of things what's actually happening. And then we do want to know about safety because if any of these functional changes are happening, we want to make sure a person feels supported, they feel like there are ways for them to still do the things that matter to them, and that they're not at any increased risk of a negative thing happening. When I say daily functional abilities, these are the things that primary care and specialty care providers are looking at. And Kari and Sarah are going to talk more about some of these in greater detail. But it's not that these are a comprehensive list, but these are the things that we specifically will be asking about. And I did want to mention that while many people talk about driving first, and of course it's very important, we tend to find these top three as the most likely to change early on because they're so complicated. And as we get older, more and more people are on medications and there's more and more appointments to keep track of. And so we tend to see these changes. We would tend to see these things change first, this entire list, before a person has changes here. And if a person is having changes here before the instrumental activities of daily living, meaning dressing before driving, there might be something else at play, and certainly something we can identify and help out with. I think it's important this is something I share with providers, but I wanted you to hear this. Compensatory strategies are a good thing, and that is expected within mild cognitive impairment. It is not an indication that a person has progressed. It does tell me there are changes happening, but certainly this is what matters most is being able to keep people independent. And that making a mistake is just a mistake. It doesn't necessarily mean a person has progressed to dementia. And so we really have to keep that in mind. And I think recognizing that will help destigmatize the evaluation process. Lastly, when a person is having changes due to or functional changes, if it's not due to the thinking ability, but rather they just don't want to do it, apathy or their mood, or there's a physical reason, that's not the same thing and not what we're not what we would consider to be an impairment for dementia. It's really important that a person is evaluated for all the potential reversible factors, because these are things that we can do to help a person in reversing or modifying or stabilizing their thinking change. And I've listed them here. I'm not going to go over this in great detail for this particular talk, but I do think this is what we tried to do in the Healthy Living with MCI series is address these factors. More and more, we see the importance of hearing and vision loss, oral hygiene, and I think sleep and substance use is absolutely critical to address for all of us, because even if it's not the primary cause of a person's thinking impairment, it certainly can help a person feel better if we optimize these things. There's a lot that goes into the evaluation, and if you're not getting a full, complete evaluation, we should be advocating and asking for that. A lot of it is looking at the other organs in the body, looking at your kidney function, your liver function, your thyroid function, looking at vitamin levels, looking at other risk factors, chronic infections, if you have had experience or exposures in the past. Brain imaging is really important in getting a sense of, is the brain smaller than they would anticipate? Is there vascular disease present? Could there be a mass that needs to be addressed by a neurosurgeon? And so this is something that should happen for anyone who is experiencing a thinking change that has a lower score on their thinking test. Cognitive screening tests, they're very helpful, but they're not the same thing as the testing we do in a memory clinic where we provide a confirmed diagnosis. Now, certainly some exceptions can exist, and I certainly would support that when a person feels confident in that. But as a patient and a family member, you should know the name of the test. You should have them write down, this was the test given. This is what we're doing with this information. This was your score. And these are the areas that you had lower points in so that we can really use that information to understand what's happening and what we should do next. I'm nearing the end here, so I really wanted to emphasize that the evaluation is just the beginning of this whole process, and there's a lot that happens after a diagnosis of MCI or even subjective cognitive decline. And that's really looking for, well, what's going on that's causing these symptoms, particularly looking for reversible factors, looking at brain diseases, which means getting the blood work I talked about, but also now getting those more advanced tests like biomarker tests looking for the proteins of Alzheimer's disease. And then talking about treatments. And this is where brain health is still the foundation of our intervention, as well as now medications to help with symptoms or to optimize other health conditions like vascular risk factors. And then, of course, we do have novel therapies now to remove that amyloid protein in the brain. I do think repeat blood work and repeat cognitive testing is warranted. We repeat blood work every 1 to 2 years for thyroid and vitamin deficiencies, even when we know a person is experiencing a condition like Alzheimer's disease. And we will repeat thinking tests, the 45-minute battery, every 1 to 3 years, depending on how a person's doing, because we want to know what the course is going to be like. But really, I think this bottom part, these last three are so essential, often overlooked in a busy clinic, and that is talking about research and clinical trials. More and more of that is happening every year. Working with these experts in occupational therapy, speech therapy, physical therapy, social work, and counseling, because there's so many other ways that we can help a person build resilience and live with these thinking changes. And then for anyone, frankly, over the age of 18, legal documents are really important. Certainly, we bring this up in a geriatric clinic for those 65 and older. But then also talking about the kind of things you want in life. What is not just does a person want their medical care to be, but how do you want to enjoy your life and enjoy your time, and how can we help a person achieve that? So as Jen mentioned, if you're interested in understanding some of the research or the caregiving topics that our field, our center is working on, you have access to the Dementia Matters podcast, and you can get that on your favorite app or on our website. I encourage you to go to our website. And then just a last minute plug, if you are interested in understanding some of the research, some of those lifestyle interventions, I have a book that will be coming out in June called When Memory Fades. And that is really based on my experience in clinic and in research. And then I tell him the story of what happened to me and my family with my father's condition. And so with that, I will stop sharing. Um, and I think I have a few minutes for questions.
Yes, you do. And we do have several here to go through, and I'm gonna let Ben and Jerry or Ben and Jamie, Ben and Jerry, sorry, Jamie, take
You have
take
ice cream?
the reins on it. Right. But I also want to see if Ben and Jamie, can we get the handouts for Dr. Chin's presentation put into the chat? Because I feel like folks will want to have that information. And then, do you guys want to share some of the questions that have come through?
Yeah, I got it, Jen. I'll do the questions. I've been kind
Okay.
of summarizing some of them. So we've got quite a few on different topics. I don't know if I can share the handouts in the chat specifically, but we can definitely make sure everyone gets them. I don't know if we'd have to send it just via email because I don't see any way to attach. But so one of the questions is, what does that initial testing or interview for MCI, or if there is one for subjective cognitive decline, does it require an extensive testing, or what does the testing type of include if someone hasn't done it before?
Well, I saw it in the beginning, it really is sitting down and getting that really thorough history. Usually there will be eventually blood work and a brain scan. An MRI is usually what we recommend, but a CT is fine too if you can't have an MRI. And then as far as that thinking test, it does still start with something like a mini mental or a SLUMS. I tend to favor what's called a MOCA, Montreal Cognitive Assessment. You have to be trained to administer that, and not every clinic can do it. It's a little bit harder than one of the other two, the mini mental and the slums. The harder, the better. And I know that's really frustrating for patients to have to go through that process, but you really want to know, is this change valid? Is it realistic? Does it align with what I'm experiencing? And then once you do have that test done, and if it is lower, I mean, if it's not lower, that's reassuring. It doesn't necessarily mean you shouldn't ask for a referral to a specialist, but it usually takes months to get in. But if it is lower, that's when you would want that referral more immediately, or at least made right away for a longer battery of tests. And that would be, in our clinic, it's about 45 minutes. In some places, because not, obviously Madison's just one city, you could just see the person giving you the test. So this is a neuropsychologist who gives the test, or frankly, in other places, an occupational therapist, a speech language pathologist administers these tests. And so you just want to have access to a longer set of tests so that they can feel more confident in saying, yes, your scores are truly lower than what we would anticipate. And so that is, I think of that testing as the second step after the initial history, but that history is so important, and it can actually provide a lot of meaningful information that can direct what we think is happening and what we can do.
Thanks. And then also, so in addition to that, for the biomarkers, how is it determined who gets tested and who kind of makes that push? And does insurance cover those types of things in some cases? And just, how does that start? Because I think a lot of folks, they may get tested, they may know something's going on, but they may not necessarily know who makes that push, who initiates that kind of process.
In general, it's going to be a specialist. So it'll be a neurologist, a geriatrician, a geriatric psychiatrist. And that's because the FDA approved test was meant for specialty clinics. So you had to be considered a memory specialist to order it. There was a second approval for a different test that's called a rule out test. And that meant that if a primary care provider said that this patient who's experiencing memory changes and has lower scores in their testing, I do not believe is Alzheimer's disease, they would then get that test. And a negative result on that test brought a lot of confidence that Alzheimer's was not present. The downside, of course, is a positive result or a non-negative result. We don't really know what that means. And so I think that could create a lot of anxiety if a person is worried about Alzheimer's. And so there is a question of whether or not we should skip that and go right to the specialist so they can get the other tests that they can offer. But it is dependent on your healthcare institution because not that many places yet have any of these tests. And so it is a matter of asking your primary care provider, Does this healthcare system offer this test? That's just blood. And so you could see a neurologist and get a lumbar puncture and get spinal fluid, or there are these imaging tests called amyloid PET scans. That usually is going to be a major academic center or major healthcare system that does it. But it's worth asking, where are these tests that I could potentially have one? Right now, though, it's meant for people with a diagnosis of mild cognitive impairment or dementia.
Jen, do we have time for much more? I know we're getting close to 10:30
Yeah,
here.
we are at the time for our break. So
Okay.
I know that I think if we can take one short question from Lacrosse, they have somebody who has a question, and then Nate, there's a lot of questions in the chat. If you're able to spend some time when Kari and Sarah are presenting, answering some of those, that would be fantastic. So
Yeah.
Lacrosse, if you want a quick answer, have that question, and then we're going to go to break.
Okay, thank you. I have a question as far as somebody that may be diagnosed with MCI due to a stroke. And then would you recommend statins with that? And could you explain what statins would do to the blood vessels?
Yeah, that's a great question. And I'll start by saying the field has debated back and forth for decades whether or not statins cause Alzheimer's disease or dementia or don't. And a more recent study that looked at all of the studies said it doesn't cause dementia. It actually could be helpful in protecting from general dementia, not Alzheimer's disease, general dementia. But people still can have brain fog with certain statins. And the brain fog is very real. It's all reversible if you stop it. But we do have to be mindful that people could have a side effect from that medication and be very careful about it. I do consider, well, certainly stroke, but even advanced narrowing of the brain. So when a radiologist looks at a person's scan and says, nope, there's a lot of narrowing, that's not normal aging, I consider that to be the equivalent of cerebral vascular disease of the brain causing a person's MCI. And I do think that warrants statin therapy for those that can tolerate it. And what it's doing is it's really stabilizing the blood vessels, keeping them healthy, through the mechanism of lowering cholesterol, also reducing inflammation. And so they're not clean drugs where they do one thing. They're actually doing multiple things, which is why we do have side effects from them, because there's multiple different pathways there. But it is inflammation, blood vessel stability, lowering cholesterol, that can be helpful. And so it is going to be I do recommend to my patients, please talk to your primary about this, or I'm happy to order this medication. And we do have to monitor though, because not everyone can tolerate it and stay on it. And so it is a matter of how a person responds.
Thank you,
Okay.
Nate, and thanks everybody for all the questions. We are at break time, so we're going to take about 10 minutes. We'll come back. Welcome back, everybody. Hope you are getting a lot out of today's program. I see Nate is really busy already answering a lot of questions that you guys have put in the chat. So thank you. Thank you, Dr. Chin, for that great presentation and the great follow-up that you're providing. So we're going to move on to the second part of our presentation, and we're going to have Kari and Sarah take over and share their screen, and we're going to learn about how occupational therapy and speech therapy can be helpful when you're living with mild cognitive impairment. So we're glad to have you guys. I'm going to hand it over.
Great, thank you. I'll get the screen sharing started here. Can you see it okay? Wonderful.
Yep, that
Wow.
looks great.
Great, wonderful, thank you. So thank you again for asking Sarah and I to join you today in discussing our roles in supporting individuals with mild cognitive impairment. We'd like to start by quickly reviewing what occupational therapy and speech therapy do. I always like to state that speech therapy is a little bit confusing as we have many titles, including speech therapist, speech language pathologist. We also help with swallowing, so we can be called swallow therapist, voice therapist, and even communication therapist. So lots of different titles for us. In our clinic where Sarah and I work, I focus mostly on supporting communication and cognition, so essentially speaking and thinking. And for both speech therapy and occupational therapy, our primary goal is to really educate patients, family members, care partners on strategies to support independence and quality of life. There is some overlap between what speech therapy and occupational therapy do, and an individual may benefit from both of us, either one of us, and we can definitely help with that decision making. As I stated, I typically work with those thinking and talking skills. Occupational therapy also addresses those cognitive functions, but they look also at those daily living challenges, those activities of daily living that we saw listed earlier. So speech therapy, occupational therapy can obviously both be very beneficial, and we can get involved at various points as there are some changes with communication and cognition. But we definitely like to say, start early. We really prefer to see people at those earlier stages so we can do great education and really maximize ongoing participation, engagement in activities, and quality of life. If we see people at the beginning stages, that's okay. It might be a short plan of care, maybe just a few visits, and we can always see people back for therapy again as there are some changes. So primary message is earlier is better for sure.
And in order to make sure that you have the most effective experience, most helpful experience with therapy, it is important to find a provider who has the proper experience and expertise. So in occupational therapy, the field is quite broad. So you can start by looking for a neurologic or neuro OT, which is different from a hands OT. So if you were sent to a hands OT, their specialty is in the areas of the bones and the muscles and the joints. So maybe if you had carpal tunnel syndrome or tennis elbow, that is going to be their area of expertise. And so you could see they might not be as helpful if you were trying to find solutions to help you with your daily activities if you have mild cognitive impairment. So OTs that specialize in neuro, our field deals with the brain and spinal cord. So individuals that have dementia, brain injury, brain tumors, Parkinson's, MS. So that is kind of our specialty area. So you're going to have a better experience if you're seeing a neuro OT. That being said, if you're in a rural area, you might not have an OT that specializes. They might not be divided into neuro and orthopedic divisions. They might have an OT that sees everything. And so you can specifically ask, have you treated individuals with mild cognitive impairment or dementia or other cognitive issues? And do you feel comfortable? So asking what their experience is absolutely okay. And if you cannot find anyone in your area that you could see, then consider telehealth. So as long as you're in the state, typically you could find a provider that has those specialties, but you might have to go outside of your specific area and do some telehealth.
When it comes to finding a speech provider who has experience with mild cognitive impairment, pretty much any adult speech therapist should have that experience. And when I say adult, we do also work with children. So obviously you want to be looking for an adult speech therapist. We are educated and trained on assessing and treating those thinking and those talking issues. So you should be able to just find a neuro-based speech therapist fairly easily. As I stated a moment ago with all those titles, I do like to state that UW is unique in that our speech therapists specialize in those different areas. And so it's important to really describe that specific area of need. Say I'm having difficulties with talking, finding words with my thinking skills, or maybe saying I'm having difficulty with eating and swallowing, or there's changes in my voice. And that way you can be directed to the best provider. Similar to what Sarah said, in those rural areas, though, that speech therapist may do all of that. So just important to ask. And we also can provide those telehealth services too if it's hard to get to a clinic setting. I wanted to start by talking about word finding difficulty because that is one of the most common concerns and reasons for a speech therapy referral. And so, what is word finding difficulty? It's also called anomia or word retrieval difficulty. And a very simple definition is it's a language problem in which a person knows the word they want to say, but they cannot retrieve it or say it in the moment that they really need it. And that word can be anything. It can be an object, it can be the name of an individual, it can be a concept. And sometimes it's not just finding a particular word, but trying to put all those words together into a sentence to really convey a story, a belief, a memory. I always like to say that who we're talking to, the environment we're talking in, and that topic that we're talking about can really also factor in and may impact our word finding difficulty. As Dr. Chin said, there are normal and age-related word finding difficulties that occur across all ages. And as we get older, we do have increased word finding. That one statistic there says 40 to 50% of adults older than 65 years old report word finding difficulty. I am below that age, and I definitely have word finding difficulty on a somewhat frequent basis. We also like to talk about it's not just finding the word, but we might have word substitution, flipping words around. We can also have some sound errors, which are called paraphasias. And I wanted to include just a few there that I found on YouTube that were fun examples of just those everyday errors that we might have. These specifically came from newscasters, so we can all understand how embarrassing those mistakes may be. But in one of the segments, the newscaster said, brush our teeth's pet, without even recognizing that they had flipped those words. That drist and mizzle, flipping those first sounds instead of saying drizzle and mist, that was a meteorologist. And then another meteorologist trying to say the word precipitation, and she just kept trying to get it out, saying it wrong, saying participation, to eventually just say it's going to rain. So just some examples of how we can have those speech and language errors. But we do know that word finding difficulty is that most prevalent and frequent symptom, of mild cognitive impairment. And we know how much the emotion is connected to word finding difficulty, and we can have that embarrassment, that frustration. And so trying to manage those emotions as best as we can is really important, because when we're feeling that way, it can make the word finding difficulty even more prevalent. We tend to have more errors. So trying to slow down, I'm often reminding myself, take a breath, slow down. That can help with finding those words or getting our words out clearly. We definitely know that when we're tired, fatigue can factor in. So end of the day, we might have more word finding difficulty because our brain has been processing all day. We like to talk about how we can become a little hyper-focused on these difficulties, and that's not to minimize what people are experiencing, but again, just to give yourself some grace when those errors occur. Try not to be too hypercritical, and just really recognize that those mistakes can happen, but if they do start to interrupt day-to-day life, maybe it's impacting our work environment, our social environment, then we definitely want to seek out that help. And as stated, sooner is always going to be better. So what are some strategies and activities that we can use to help promote word finding? These are just a few of the primary ones. So pausing, like I said a moment ago, take that breath, give your brain and your mouth a moment to synchronize better. See if you can describe the word, maybe the person, the place. Using body language, gesturing can really help with either finding that word or trying to get that word across. Sometimes we substitute, like in that example, the meteorologist could not say precipitation, so she used rain, and that was quite okay. Sometimes we can name the category to get to the main word, but ultimately I always talk about self-advocacy. And what I mean by that is letting your communication partner know what you need from them, telling them, hey, give me a moment, slow down, or even, hey, jump in here and help me out. I think it's really important that we let our communication partner know what we need from them. And these strategies help us when we're trying to find that word, but it also gives clues to our communication partner so they can jump in and help us. When it comes to activities, Dr. Chin started with a great question, and it's really going to highlight the recommendation that I make quite frequently in my clinic. And one of them is talking. So make sure we're still using our speech and language functionally. Try not to avoid, try to really engage in those social situations as best as we can. Reading, and especially reading out loud, can be a really great activity. I saw in the chat many people saying that they're in book clubs or enjoy reading. Also read out loud. When we read out loud, it helps strengthen our word recall. We see, we hear, and it helps us to understand those words a little bit better, which might help us to then later retrieve that word. It's a very low pressure activity, meaning we don't have to read to anyone. We can read to ourselves. We can read to our pet. Not a lot of pressure when we're reading out loud. And then it does also help support our memory. When we're reading out loud, we're not only seeing the words, but we're hearing the words. And so that helps us to maybe remember those words. As we mentioned, there's lots of good word games out there. And again, I was really happy to see all the different activities that people are engaging in. There is one study that I wanted to mention that occurred at Duke in 2022, and they were looking at computerized crossword puzzles versus computerized cognitive games. And there were 107 participants with mild cognitive impairment. And what they found were people who engaged in those crossword puzzles actually had better outcomes than people that were engaging in other computer-based activities. And when they say medium difficulty crossword puzzles, those were the ones that are equivalent to the New York Times Thursday puzzle. So if you're engaging in those crossword puzzles, you're doing a great job. But ultimately, engaging in any type of game activity, it's going to help us with our brain function. It's often a social activity, and it's just a really great way to engage with others. I want to share this handout. This is a very busy screen, but this is a handout that I give out quite often in my clinic setting, and it's really going to encompass what I've already been talking about, which is word retrieval, what exactly it is. This is a more robust definition. What are some of those strategies for our partner, and then some of those home-based activities again that I've listed. I do want to highlight one thing on here that I did not talk about is that number 7, which is pre-planning. And I always like to highlight that as an excellent strategy too, because that can help us when we're going into a situation, whether that is a telephone call, maybe it's a social setting, maybe it's a medical appointment. If we do some of that pre-planning, that's going to reduce our anxiety, that's going to help us to be better prepared, might help us to communicate a little bit better. And that can be writing questions down, words down. It can even be just rehearsing in our mind. And then I also wanted to touch upon how important it is to recognize that communication challenges are often more complex than just struggling with a single word. It might be losing our train of thought in the middle of a sentence or conversation, and that as well can be very frustrating. And so there are some strategies that we can use in the moment when we have that loss of thought or even in advance. So in the moment, again, pause, breathe, take a moment, see if that helps you to just get back on track. Rewind, which also means replay the topic or context in your mind to see if it can bring you back. Acknowledge, once again, that advocacy. Let people know, oh gosh, what was I saying? I forgot what I was saying. Can you jump in here and help me? Most of the time, people are going to be very willing to do that. And then sometimes we just have to move on. It's okay to say, well, I'm not sure what I was saying there. Let's move on. I'll come back to it later. In advance of a talking situation, these are some strategies that we can also do. And one of the most important ones is modifying that environment. The environment in having distractions reduced is very important because when we remove those distractions, it also reduces the cognitive load. And having too much going on at once is often the primary reason for that loss of thought or topic. So making sure that we modify the environment. We can also use some notes. So again, before that conversation, having some written notes in advance to prepare us. Even using notes during can be really effective. I use that in my clinic setting quite often. I have a whiteboard or LCD board, and I might write down the topic or a couple keywords during, and that can then help the individual to stay on topic. They can refer to it and keep that topic of conversation going. So those are several word finding strategies that are out there and lots of great resources.
Thanks, Kari. So as Dr. Chin mentioned, there is a relationship between anxiety and stress and our thinking skills. And I know that there was a question that came through while Dr. Chin was talking about how stress can affect cognition. And there is a definite relationship between them. Our state of mental health really can affect our thinking skills. The research has shown that it's really intertwined. Our state of mental health, which includes anxiety, depression, or stress, and cognition. And those relationships are pretty complex, but they have been established across many different research studies. The analogy that I like to use is thinking of our brain as a computer. And we all know that sometimes when we're on a computer and if we have too many windows open, we have a lot of different programs running at one time, our computer can get bogged down and some of those programs can run a little bit slower. The computer might not work as well. And it's similar with our brains, our nervous system. When we have so many systems going on, thinking of stress, if you just have some underlying stress that is kind of running at the baseline, or if you have anxiety, a lot of anxious thoughts that are going through your mind, that is like a program running, and you're trying to do other things. You're trying to go about your daily life. You're trying to remember things. All of your systems are not going to work as well if you kind of have this underlying stress and anxiety, or if you're dealing with depression. And so those things are all interwoven together. And so it's important to address those when we're trying to think about optimizing our thinking skills, making our thinking skills work at their best. We definitely want to address anxiety, stress, and depression. And we know that they're interrelated. And so if you might have a memory lapse, you might struggle with your memory, and then you're anxious about that. You're like, what is going on? Does this mean that I'm going to develop dementia? And then you start hyper focusing on that. That can actually lead to greater challenges with your memory. And so it's sort of a self-fulfilling prophecy. And so, as Kari said, we don't want to minimize these issues. We want to address them, but you also don't want to hyper-focus. And so the next slide will show that there are many different factors that play into our thinking skills, and some of them are reversible and modifiable, and those are always where we want to start when we think about trying to optimize or improve our cognitive performance. Things like medication can absolutely affect our thinking skills. If you're sleeping poorly, that's going to affect your thinking skills. If you have stress and anxiety and depression, those are all modifiable factors. And so we like to start with those. And that's where this thorough history comes in. We're trying to figure out what could be contributing factors to some of the memory challenges or other challenges that you're having cognitively. And the next slide talks about just how we all have cognitive challenges at certain times. Dr. Chin talked about our brains kind of being at their peak in their mid to late 20s. And so this is a survey of individuals with an average age of 27. Their brains should be at their healthiest. And it's showing that even individuals, when they're at their prime, had struggles in terms of finding a word or going into a room and forgetting what they went into the room for, or forgetting where they put something, or going to the store and forgetting. So we all have these momentary lapses of our memory or other cognitive skills. And so normalizing those intermittent challenges so that we don't sort of get into that anxiety cycle where we're hyper-focusing and getting anxious about everything. So as I said, it really is this balance. You don't want to have too much focus on the cognitive challenges, but you also don't want to ignore them altogether. We want to not have some of the negative self-talk that can happen. Why can't I remember this? I'm so stupid, or I didn't struggle with this ever before, and now I'm struggling with it. What's wrong with me? All of those thoughts really aren't helpful. So trying to keep our nervous system in a calm state is going to help your thinking skills really work at their best. So once we do identify the challenges, then we can start to work on specific strategies. So on the next slide, so we really want to think about what specific tasks are you struggling with? And then within those tasks, what does the challenge seem to be? Is it more with attention or with memory? Is it just the sort of getting up and getting started, that initiation piece? Is it with sort of organizing your thoughts or some of those higher level cognitive skills that Dr. Chin talked about called executive functions? So really teasing out what types of challenges you're having and when those are occurring, that can help us figure out what strategies will be best. We really do come up with different strategies based on the task that you're struggling with, as well as the type of cognitive challenge. So it's very specific, and that's where the interview really is important. So in occupational therapy and in speech therapy, some of the strategies that we will educate you on in terms of trying to help your performance, some of the strategies really are trying to improve the underlying skills. So those are called internal strategies, strategies to try and improve memory or improve attention. So the graphic over to the right, it talks about visualization and linking. Those are just two examples of a memory strategy. So if you're struggling to remember something, it might help to form a visual picture in your mind. That's a visualization strategy. The research says that the more interesting you make that visual picture, the more likely your brain will be to remember it. We talk about, often it's hard to remember what you did the previous day or where you put your keys. Those are very mundane things that we do time and time again, day in and day out. Our brain doesn't really prioritize that type of information to remember. But if something is interesting or odd or unusual, then our brain tends to prioritize that. It has a higher likelihood of paying attention to it. And we know that attention really is the bedrock of memory. If our brain doesn't pay attention to it, it doesn't have as much of a chance to really encode that or get that memory stored. So making the visual picture very interesting or odd or silly will be more interesting and more likely to be remembered. And then linking is just one other memory strategy. It's trying to associate or link one memory with another. We know that we have a lot of memories that are contained in our brain. Even if we struggle with memory, we know that we have a lot of memories that are stored and able to be retrieved. And so it's trying to take advantage of that. Rather than forming a new pathway, forming a new road to form a new memory, can we take advantage of one of the pathways that's already existing? So I myself struggle with remembering names, and so I use this linking or association strategy to try and remember names. So if I meet someone who has a name of someone else that I know, I try to link those two individuals together in my brain, and I'll form a visual picture, trying to form some type of interesting visual picture of the two of those individuals together so that I can share that pathway. I already have a road built. Why not travel on that one rather than do the work of building a new road? So those are just a couple of examples of internal strategies. And there are other memory strategies, and there are other strategies to help with attention as well. And then we also review external strategies. So these are the compensations. And as Dr. Chin said, compensations are not bad. We all have a lot going on in our lives, and we all need help. We all need support to help us manage all the things that we do in our day. And so using things like calendars and lists and using electronic reminders or alarms, those are helpful things that can help us manage our responsibilities. And they're not bad and they're not wrong. They are helpful. So over there on the right-hand side, that graphic shows Google Keep. That's just one example of an electronic strategy. It's a note-taking app that has a lot of features that include being able to record audio messages. You can take photos. It has a lot of different methods that you can organize the information so that you can find it easily. So that's an app that we recommend highly as a strategy. And then another strategy is trying to reach out to receive appropriate support from others. So part of our education, if you're coming to therapy, is really working with your care partners, working with family members or friends, and teaching them how to provide appropriate support so that they're not doing too much. We want them to provide support, but not do tasks for you. So we talk about this cueing rather than doing, having appropriate cues so that you yourselves are doing the task rather than them just totally taking it over for you. So just some instruction on how to do that best can be included in our therapy. This slide just talks about another thing that we can review in occupational therapy. And often if you're seeing a counselor or a talk therapist, this is the strategies that they can review as well to help manage some of the stress or anxiety that might be hindering cognitive performance, is reviewing strategies to help regulate and calm the nervous system. As I said, that's one of the most helpful things you can do to help your thinking skills work at their best, is to calm the nervous system. So instead of panicking when you can't find a word, or instead of becoming anxious when you experience a challenge, taking a breath, pausing, maybe doing some breathing strategies could be a first step. So this rectangle breathing and the 5-finger breathing are just 2 examples of what are called focused breathing techniques, ways to help slow down your breathing, which in result helps to slow down your heart rate, and can be a very calming thing for the nervous system so that your systems can work at their best in terms of thinking. The next slide talks about other strategies that we can use are changing the environment. So reducing distractions, keeping things organized, keeping things simplified so there isn't as much external distraction or confusion. Using visual cues. So it's okay to use Post-it notes and put them on your bathroom mirror to help you remember, or a Post-it note on your back door if you need to remember something when you're going out the back door. Or if you need to take something with you, literally put it in front of the door so that you're going to step over it. Those are okay. Those are appropriate cues to help you. And then altering the task demands. So you're kind of changing the task so it's a more appropriate level of challenge for you. So maybe if you struggle to remember things that you're reading, to help with your attention, as I said, attention is the bedrock of memory, you could try to listen to an audiobook while you're also reading it, and maybe listening to it in smaller chunks. So just reading a smaller piece rather than trying to read for an extended period of time. You're likely to have better recall than if you're reading for an extended period of time. Even using external cues like tracing your finger on the page, or using a ruler or a colored piece of paper to help your attention stay on the line that you're on. Little things like that can help our attention and in turn help our memory. So those are just some additional strategies. And then on the next slide, we're going to transition to what's in our control. So Kari is now going to talk about some additional strategies that can help our brain health.
Exactly. So trying to find what is in our control, identifying what we can do to maintain brain health. And there is research that has identified a number of them. And if you were watching those videos during the break, one of them actually highlighted brain health and healthy lifestyle choices. So that was a great video. This is one handout that we share, and there are many versions of this, and I have seen it come from many different clinics, and including Dr. Chin's clinic, just really highlighting what can we do to maintain brain health. On the left is this SHIELD acronym, and on the right, it's a little bit more detailed. We know that we need to get good sleep. Good quality sleep is very important. It rejuvenates us and makes us ready for that next day. We want to be cognitively and socially active. So stimulate your mind, challenge your mind a little bit. Just being social and communicating with other people is really important for brain health. We also want to challenge our brain. We talked about those different brain games and activities. Anything that's going to challenge us a little bit is what's most important. We also want to eat healthy, so making sure that we're having a healthy diet. We want to make sure we're exercising our body. So we've talked a lot about exercising our brain, but physical exercise is also very important for brain health, making sure you're getting that heart rate up a little bit as best as you can. And then treating any underlying depression or anxiety is also really important. And on that SHIELD, you see that stress, really being able to handle and manage stress as best as we can. This is another handout that we like to give to people that has another acronym called DANCERS. So again, highlighting these important areas, disease management. So making sure if you have other health-related conditions, that those are being addressed by your medical provider. There's that activity again. So that physical exercise, that nutrition, so eating healthy, the cognitive stimulation, that socialization, there's that E, engaging with others. relaxation, so making sure that we're managing stress and trying not to get too anxious and stressed out, and then sleep, so that importance of sleep again. So these are handouts that we will often give in lots of different clinics that really talk about what we can do and what we can have in our control. And I like to say this is at any age. I'm always working on these as best as I can too, to maintain my good cognitive brain health.
All right, so now we'll transition into questions about driving. This is one of the most common questions and some questions that we received prior to this presentation. And so definitely wanted to touch upon this. As Dr. Chin said, driving isn't often the first issue that individuals with mild cognitive impairment will experience. Usually it's in many of the other areas of activities of daily living, but this can become a question a little bit down the road. So I wanted to touch upon that. So how do we determine whether it's safe to continue driving? Sometimes family members will be the ones that start to ask those questions. Sometimes providers will be the ones that bring this issue up. The individual themselves may or may not have concerns. Many times, an individual might feel like they are still competent in driving, but it's others that are starting to raise questions. And so how do we come about this decision? So the slide here, it does show that we use many different pieces of information to help make the decision. So the patient's understanding of their own abilities, the family member's observations or their concerns, the evaluation that the physician performs, absolutely, those are part of the decision-making process. Thinking of what are the habits and routines that an individual does in terms of their driving routine. Are they driving very locally? Are they driving farther? Are they driving in the evening and at dark? Are they driving on highways or only local roads? Those can play a factor. If needed, we can do a clinical driver assessment to try to get some more objective information about someone's skills in relationship to driving. And I'll talk about that in the next slides. And then if needed, an individual can do a behind the wheel evaluation. So all of those in terms of input, in terms of making the decision, they're all factored in, as well as ethics. So the next slide talks about kind of some of the negatives that can happen if an individual does stop driving. So they can become socially isolated. It can lead to depression. Maybe if they're still working, they're no longer able to work because they can't have that transportation to and from work. Definitely it can be a burden for caregivers, or if they're paying for transportation services, that can be costly and that can be inconsistent in terms of how reliable those services are. But yet we know that driving unsafely is a public safety issue. And so on the next slide, it kind of shows this balance. We know that we want individuals to maintain their independence for as long as possible. And yet driving is a very high risk activity. It's a higher risk activity than most other tasks that we do. We talk about an individual, making choices that might be risky, but most of them only impact themselves. If an individual is going to climb onto a ladder, maybe they would fall and be at risk of injuring and breaking a bone or hitting their head, but that's only injuring themselves. If someone is driving unsafely, they might be risking their own safety, but it's also putting the safety of the general public. So we have to factor all of that in. So when we talk about some of the considerations on whether or not someone should drive, we absolutely need to look at their cognitive abilities. And I won't go through this slide in detail, but some of the most important ones that we're looking at are some of the processing speed. As Dr. Chin mentioned, with aging, processing speed does tend to slow. And so how slow is it? Is it slowing so much that that is a significant risk factor? Having difficulties with wayfinding. So as an individual getting lost or starting to become a little confused as they're trying to drive on different routes. How is their attention? Can they multitask, do two things at once? We know often when driving, our mind might be wandering. And so we might not feel like we're doing two things at once. But if your mind is somewhere else while you're driving, it truly is multitasking. And so is an individual kind of able to keep that divided attention would be the technical term. How's their judgment? And are they having difficulties with some of those other activities of daily living? If they're struggling with some of those other tasks in a home that is a very well-controlled environment and is probably quiet, and they're able to kind of set up their optimal environment. Well, on the road, you really don't have that control. It is not well controlled, and there's many different things going on at once. And so it's a higher demand. So if they're struggling with certain tasks at home, that can be a red flag. The next slide talks about just driving abilities. And so these are all, again, things to just look for. Are you yourself or is your loved one showing any of these red flags? Are they, having difficulties? Are they starting to hit curbs, or have they had any fender benders when they're backing up or backing out of a driveway? Are they hitting curbs, or are they having difficulties following some of the signage, or maybe not noticing when a car next to them is merging, or if there are construction workers on the side of the road, are they getting a little too close, or are they noticing things very well around them? Are they driving an inappropriate speed? And that might actually be more likely to be a slow speed. And we talk about how driving below the speed limit is actually a risk factor that individuals don't think about. Many individuals that we see for testing will come in and they say, I'm very good, I'm driving, very slow. And their family member will say they're driving below the speed limit. And that is a risk factor because that's usually not expected. Most drivers drive at or above the speed limit. And so when someone's driving slow, that can be a risk factor. And then, as I said, are there a history of kind of some traffic violations or maybe these minor fender benders, and that can show that maybe there's something going on that needs to be further evaluated. So in terms of the OT clinical driver assessment, this really just is a way to provide more objective testing to help inform the decision-making about driving. This is not a total pass-fail test. If you don't do well on the OT evaluation, if there's one test, it's not a pass-fail that, you failed the entire thing if your scores are low on one test. But we're just trying to gain additional information and inform the decision-making. So with the assessment, we do look at muscle strength, coordination, sensation. We're looking at neck range of motion. We are looking at that reaction time, looking at some different cognitive skills, including memory and attention and executive functioning. We're looking at visual perception, which is how the brain and the eyes communicate, or how the eyes interpret what you see. Visual scanning, and then if needed, we can screen vision. Next slide. Sorry, let me advance. I'm also on my own slides here. So in terms of receiving this clinical OT assessment, in the Madison area, there are a couple of ways to do it. So you would need a referral for occupational therapy, but the referral cannot say driving evaluation. Insurance will not typically cover the evaluation if it is for driving evaluation. And so in the Madison area, if the referral is within the UW system, the referral should say OT IADL evaluation. That's instrumental activities of daily living evaluation. That's our code for OT clinical driver evaluation, but we just use that term so that insurance will cover it. And if the referral is being sent to Meritor Unity Point Health, who also perform these types of evaluation, their term is complex ADL evaluation. So it's the same evaluation, it's just two different terms for the different systems, UW versus Meritor. And if you're not in the Madison area, you'd have to contact the neuro OT department or the OT that you're seeing and see what type of verbiage should be put on the OT referral. But unless you're already being seen by an occupational therapist, you would just need a new OT referral to get this process started. And when individuals come to see us for these OT clinical driver evaluations, They are often concerned that we're going to send the report directly to the DMV, and we do not send this information to the DMV. Our assessment results are sent to the provider who referred to occupational therapy, and that could be an MD, it could be a DO or a PA or an NP, one of those advanced care practitioners. Those are all of the providers who make the decision about medical clearance for driving. And so we send the results of our evaluation along with our impression and our recommendation to that referring provider. And then they determine what the appropriate next steps would be. And those next steps might be that the individual looks good, they did very well, and according to all of the other input, the individual is allowed to continue to drive. Or it could be that more information is needed, and so a behind the wheel evaluation is recommended. And that could be with the DMV or with a private company, and we give information on what the options are when you would see us with OT. Or it could be maybe driving with some restrictions. And those restrictions could be maybe driving during daytime only, or only with a co-pilot with someone in the car, or within a certain radius from home, or maybe no driving in inclement weather or on highways. Some of those restrictions can be more informal, where they are simply recommendations from the medical provider. Some could be formalized where it has to be a restriction on the driver's license. So it's very individualized in terms of what could happen after the clinical OT evaluation. The next step is always talking to the provider and figuring out what is an appropriate next step. And that is all I will have for today. And now we have a little bit of time for some questions.
That was fantastic. Thank you, Kari and Sarah, for sharing all of that information. We do have a few minutes for some questions. So does anyone have any? I do see Dr. Chin has been very busy during the presentations. You guys did such a great job sharing concrete examples. We did have somebody ask if you could just share, go back to, it would be slide, I think they might have wanted to take a picture of it. So let me just see which slide it was.
Sure.
The really heavy worded one.
Was it the word finding?
Yes,
Yeah.
Slide number 6. Yeah. Mm-hmm.
Yep, number
word
7.
retrieval.
Let me share that again.
And we'll email everybody the handouts for both Dr. Chin and Kari and Sarah's presentations today after the program.
Was it this one?
Yes, I believe so.
Yeah, absolutely. I'll keep it
So
up
we
there.
can keep that on if there's any additional questions here.
But yes, it's a busy handout, but it's a one that I give out quite a lot for lots of different reasons and diagnoses, but it's a nice comprehensive summary of strategies and activities.
I will say that I've been providing care and support type services for folks living with mild cognitive impairment for a decade. And everything that you guys have shared is things that we talk about in those kind of coaching services that are provided. So, I think the takeaway of your presentation today is that there are support services that your insurance can potentially cover that are available to you that can really help make life easier and maybe even help calm down some of the anxieties or fears that one might have just simply by living with an MCI diagnosis. And that carrying that burden of worry without having strategies to support the things that are changing that others can't see in your daily life, but you certainly know are there. These services are available and can be really, really helpful in just overall quality of life. So
great.
Awesome. Were there any additional questions in the chat, Ben and Jamie, that we should attend to?
I do see one question that says here, as a current OT student, what things can we do to help destigmatize cognitive decline and MCI so that patients can feel comfortable advocating and receiving early treatment and help?
That's a great question.
Well, I think that Dr. Chin's presentation was very helpful. So even if you're able to share some of those slides, maybe make some screenshots of those slides and talk about how it is normal to have some degree of cognitive change with aging, but then trying to tease out, is it true cognitive impairment, like a mild cognitive impairment, or is it just natural aging? And then going from there, but talking about how everybody has some type of decline with age. So that's the normalization piece. And then just advocating that, there are services available, and the earlier the better if there are, more significant impairments identified.
Okay, well, I want to thank the three of you for just an incredibly comprehensive, informative, helpful topic to present on today. This was really great. Jamie, could you share, we have some closing slides. We want to share some information with you about some things coming up at the Research Center, some opportunities that are available to you, and just talk a little bit about our community partners. So if you have a question that comes up after today's presentation, or we happened to miss it, please feel free to reach out to our general questions email, and we will find a way to get those questions answered for you. That is a great way to stay connected to the Research Center. If you've been diagnosed with mild cognitive impairment or support someone living with MCI, whether personally or professionally, we have created a Next Steps After Diagnosis webpage, which houses a glossary of resources that you can use to navigate life following a diagnosis. You can also listen to a recent Dementia Matters podcast where Dr. Chin and I discuss the next steps after receiving an MCI diagnosis. So links to that information are being put in the chat as we are going through the slides. And you can also find this information on our Healthy Living with MCI webpage as well. We would like to thank all of our host site partners and recognize the work that they do. These partners are all dementia care specialists from 7 Wisconsin counties and 1 tribal nation. Dementia care specialists are professionals embedded within the Aging and Disability Resource Centers. There's a slip of my tongue, Kari. Or tribal agencies who focus on supporting individuals living with memory and thinking changes. They offer a range of services, including information and support, memory screenings, care plan assistance, and connections to social and support opportunities. Their goal is to help people living with memory and thinking changes continue to live their best lives. Support is also provided to care partners and caregivers. More information can be found about the Aging and Disability Resource Centers across Wisconsin at the website listed on the site. And then we would also like to recognize the Oneida Comprehensive Health Division. Oneida Comprehensive Health Division offers a broad range of health-related services for members of the Oneida Nation, their descendants, and other tribes that acknowledge and incorporate foundational elements of Oneida Nation history and culture. Community members can access medical, dental, and optical care, therapy services, behavioral health services, community health services, pharmacy and skilled nursing care services, as well as telehealth services. Employees of the Oneida Nation can also receive employee health services. You can visit the Oneida Nation website or contact the dementia care specialist to learn more. So we're ending our 2025 series and we're looking forward to 2026, and our first Healthy Living program in our series will take place on Friday, March 6th We are so excited to have our guest speaker, Dr. Beth Olson, who will be talking on the topic of ultra-processed foods. And she has shared with me that, I don't know if it's just a happenstance or serendipity, but she has sent me a message saying, I have so many requests to talk about ultra-processed foods. So it's a hot topic. But learn what ultra-processed foods are and explore why people who eat less of these packaged foods tend to have better health outcomes. Leave with gaining some confidence in making food choices that support your brain health and overall well-being. So if you go to the link or scan the QR code, you can find out more information and you can register. If you haven't tuned in to hear a Dementia Matters podcast, I highly recommend that you do so. Dr. Chin has great conversations with leading scientists and caregiving experts, and he brings listeners the latest in Alzheimer's disease news, research, and caregiver resources. In fact, I just listened to his latest interview, which happened to be with Kari and Sarah. So if you want to learn more about their services, you can listen to that podcast. And if you are looking for ways to stay connected and up to date on news and events happening at the Wisconsin Alzheimer's Research Center, consider subscribing to the center's e-news called Headlines. If you're interested in learning more about research that's taking place at the Research Center, you can visit the center's Open Studies webpage, where you can find information on studies that are actively recruiting participants. And lastly, we encourage you to complete the program survey for today. I have to tell you that today's program was put together because of specific information that folks have shared with us about what they wanted to learn about in past surveys. So please let us know if today's program was helpful for you, and if there's other information that you would like to know about. We look at them, we review them every year, and then we try to build on the things that you guys are looking to hear about. So scan the QR code, let us know how we're doing, and that is also in the chat if that's more helpful. So with that, I want to thank you for being with us today. And thank you again, Dr. Chin and Kari and Sarah, for the great information that you've shared with everyone. We wish you a joyous holiday season, a happy and healthy new year, and we hope that you'll join us again in March. So until then, be well and take care.
Everyone.
Jamie, could you go back to the last slide and just put that QR code up there a little bit? Thank you all.
Thank you again.
Thanks.
Thanks. Bye-bye.
Thanks, Kari and Sarah. Bye-bye.
Bye.